Hello and welcome everyone. Today we are discussing about ovary. In this video we are going to discuss about anatomy, histology and pathology related to ovary. Ovary is a female gonad. It is paired intraperitoneal endocrine organ typically found in lower left and right quadrants of abdomen respectively. Ovaries play fundamental role in reproduction as well as production of hormones. Ovaries are found close to fallopian tubes within ovarian fossa. Ovarian fossa is composed of bifurcation of external iliac artery and internal iliac artery. Anterior to the ovary is medial umbilical ligament. Posterior is ureter and internal iliac artery. Superior to ovary is infundibulum of uterine tube along with suspensory or infundibulopelvic ligament, which is the posterior extension of broad ligament of uterus, and it is also called mesoovarium. The ovary is connected to body wall by suspensory ligament of ovary. Ovary has two ligaments. The suspensory ligament carries both the ovarian artery and vein as well as sympathetic and parasympathetic plexuses. The proper ligament of ovary is remnant of gubernaculum and does not contain any vessels. The normal ovary is 2 cm in width, 3.5 cm in length and 1 cm in thickness. It is comparable to the size of a golf ball. Ovary has a dual blood supply from both ovarian artery and uterine artery. The ovarian artery is a paired structure that originates from abdominal aorta below the renal artery or around L2 level. The artery runs through suspensory ligament of ovary, which then enters the mesoovarium. The ovarian artery may make an anastomosis with the uterine artery within the broad ligament. Ovarian vein, which travels to ovary by suspensory ligament, provides the drainage to parametrium, cervix, mesosalpinx and pampiniform plexus as well. A left ovarian vein voids its content into left renal vein, while right ovarian vein empties directly into inferior vena cava. The ovaries drain majority of their lymph into para-aortic lymph nodes, which arises around level of L2. Lymph that follows vessels close to round ligament leading to external iliac and inguinal lymph nodes. Now let's learn about histology of ovary. The outer epithelium of ovary is made up of simple cuboidal and it is called germinal epithelium. Underneath this layer is a connective tissue made up of collagen and it's called tunica albuginea. The next zone contains ovarian follicles, which is called the cortex. Here follicles of different sizes and maturity can be seen. The most central zone is medulla. It is made up of loose connective tissue and contains major blood vessels. This region is also called hilus. The germinal epithelium is made up of simple cuboidal epithelial cells. Now let's learn in detail about follicles. Ovarian follicular development begins while female fetus is in utero. During 5th week of pregnancy, female fetus's ovary contain about 500 to 1300 primordial germ cells. The primordial germ cells undergo mitosis and by the 20th week of pregnancy, female fetus has approximately 6 to 7 million germ cells. Peripartum, each germ cell cyst regresses to form primordial follicle containing an oocyst and a single layer of nourishing granulosa cells. Many germ cells are lost during this process and female is born with 1 to 2 million primordial follicles. By the time she reaches puberty, approximately 400,000 to 500,000 primordial follicles remain. After menarche, approximately 1,000 follicles are lost monthly, and after 35 years of age, the rate of follicular loss increases. Ovarian follicular development takes place in peripheral cortex of ovary. It takes approximately 1 year for a primordial follicle to mature before ovulation. Most of this time is spent in gonadotropin independent phase. Gonadotropin independent growth relies on local growth factors beginning with the maturation of primordial follicle and ending before the follicle develops a fluid filled space. Primordial follicles transition into primary follicles through oocyte enlargement and granulosa cell layer proliferation, which then starts to express FSH receptors. As primary follicles become secondary follicles, the simple cuboidal epithelium of primary follicle transforms into stratified columnar epithelium. The primary follicle stroma develops blood vessels and differentiate into theca interna and theca externa. The theca interna develops LH receptors. The FSH and LH receptors enable follicle to respond to their respective gonadotropins. Further maturation of secondary follicles and selection of dominant follicle for ovulation is gonadotropin dependent. FSH bind to the FSH receptor in granulosa cell layer of secondary follicle. In response to FSH stimulation, follicle continue to grow and develop a fluid filled space. This space is referred to as an antrum and contains secondary material from growing oocyte and granulosa cells. LH bind to LH receptors of theca interna, resulting in production of androgens. As ovarian follicles mature, the larger follicles can use enzyme aromatase to convert androgens into estrogen. Increasing estrogen levels send a negative feedback signal to hypothalamic pituitary adrenal axis, decreasing the circulating level of FSH. Large follicle remains sensitive to decreasing level of FSH. A large follicle is selected as a dominant follicle and continues to mature through a rapid proliferation of granulosa and theca cells. The antrum also enlarges rapidly. Granulosa cells of dominant pre-ovulatory follicle develop high concentration of LH receptors and become responsive to LH surge. The LH surge is caused by further increasing in circulating estrogen made by pre-ovulatory follicles and result in ovulation. During ovulation, the follicle releases its mature oocyte for fertilization. After ovulation, empty follicle develops into corpus luteum as the granulosa and theca cells become granulosa lutein cells and theca lutein cells respectively. The corpus luteum secretes progesterone and estrogen to support implantation and early pregnancy. If implantation does not occur, the corpus luteum degenerates into connective tissue structure known as corpus albicans. Now let's learn about physiological variants of ovaries. First is cyst. It can be functional and benign. Simple ovarian or functional cysts occur naturally with changing levels of hormone during the menstrual cycle. The second is accessory and supernumerary ovary. In accessory ovary, there are more than 2 ovaries attached to the typical ligaments, and in supernumerary ovary, they do not connect via typical ligament. In a single ovary, the genetic defect or mechanical errors which leads to degeneration of one of the ovary leads to single ovary. In patients with Turner syndrome who have a streaked or atrophied ovaries, the ovaries start developing and functioning normally, but ovarian tissue will soon begin to degenerate before birth. Instead of having over 2 million oocytes, the patient with Turner syndrome will have markedly less oocytes. Now let's learn about benign lesions of ovary. Gonadal dysgenesis or agenesis. Inflammations like acute inflammation, granulomatous pelvic inflammatory disease, xanthogranulomatous inflammation, calcification, PCOD, torsion, endometriosis, endosalpingiosis. Now let's learn about tumor pathology of ovary. They are serous mucinous endometrioid or clear cell cyst adenoma, adenofibroma, surface papilloma, Brenner tumor, sex cord tumors like Leydig cell tumor, granulosa cell tumor, thecoma, Sertoli cell tumor, gynandroblastoma, germ cells tumors like choriocarcinoma, dysgerminoma, embryonal carcinoma. Mixed germ cells tumor, teratoma, yolk sac tumor, serous mucinous endometrioid clear cell carcinoma, malignant Brenner tumor. These are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.